All right, ready to go?
We are ready.
Wonderful. Welcome, everyone. We're going to get started with our discussion today on Genetic Testing 101. Thank you for joining us, and thank you to our sponsor for this webinar, X4 Pharmaceuticals. I'm Kate Bodiger, the Executive Director for the National Neutropenia Network, and we appreciate that everyone is here today. We are recording this webinar, and it will be available through our website as well as our YouTube channel. You can submit questions at any time. At the bottom of your screen, there is a toolbar, and you'll see the Q&A or question and answers. If you click on the Q&A, a box will pop up where you can type your question and hit send. We will be compiling the questions and share those with Dr. Link at the end of the webinar. So thank you, Dr. Link, for being here today. We appreciate it. And I will let him take this over. Thanks, everyone.
Thanks, Kate, for the introduction, and good afternoon. As Kate mentioned, I'm a hematologist who specializes in the diagnosis and treatment of persons with neutropenia. I'm also a scientist who's been working in the field for over 25 years to understand causes of neutropenia and treatments of neutropenia. One of the most common questions that I hear from doctors and patients is whether genetic testing is worthwhile. I can simply say that for the great majority of individuals, the answer is an unqualified yes. In this webinar, I will review the pros and cons of genetic testing. So we will cover how genetic testing is done in a later slide, but just to make sure we're all on the same page, simply put, genetic testing is how we look for gene mutations in somebody's genome. In today's discussion, we're focusing on mutations that are known or suspected to cause neutropenia or some other primary immune deficiency. Genetic testing has the potential to impact care of patients with neutropenia in several ways. First, it can help establish a diagnosis. Second, it can suggest a certain type of therapy or a clinical trial. And finally, it can be used to identify other family members at risk and for family planning purposes. Over the past 10 years, there's been tremendous progress made in our understanding of the genetic causes of neutropenia and how this information can be used to impact on clinical management. In my view, it is more important than ever to have genetic testing done early in the evaluation of somebody who has chronic neutropenia or other primary immune deficiency. And this is illustrated by a recent study that was supported by the Jeffrey Modell Foundation. And it kind of illustrates the importance of genetic testing. So this was a study in which they had 158 people who carried a diagnosis of primary immune deficiency, or PID. These patients did not have a genetic testing done in the past. And this was mostly because of cost concerns. So this study offered free genetic testing using the Invitae gene panel that at the time included 307 genes. So here are the results. So genetic testing resulted in a change in diagnosis in almost half of the cases. It led to a change in treatment in 36% of cases, and it changed outcomes as judged by the study in 45% of cases. You know, bottom line from this study is that even if you have a clinical diagnosis, genetic testing can affect outcomes in about half the time. In my own practice, I remember a case very well where genetic testing played a role. We had a young person, I think 3 or 4 years old, who had severe neutropenia that had some unusual clinical features and was resistant to G-CSF. So we got genetic testing done, and it identified kind of unusual cause of neutropenia. And in knowing about that cause, we knew that the prognosis for this patient was very poor without transplant. So we recommended an allogeneic transplant, which was done quickly, and the patient is doing well. So that was a clear-cut case where the diagnosis impacted on what we recommended for treatment. So here's another example of how genetic testing can be used. This is an example focused on WHIM syndrome. So WHIM syndrome is a rare clinical condition that is characterized by neutropenia, lymphopenia, and warts. However, some patients only present with neutropenia, so some of these patients do not get the diagnosis of WHIM syndrome. Now, we know that almost all cases of WHIM syndrome are due to mutations of CXCR4. So in work done in part by my laboratory, we know that, well, neutrophils are where neutrophils are made in the bone marrow, and they are released in a regulated fashion into the blood. Now, the blood is where neutrophils need to be to fight infections. This process of release is regulated. The gatekeeper for this is CXCR4. In WHIM syndrome, the mutations make this signal too strong, and neutrophils then get stuck in the marrow, and they can't get out, and you get neutropenia. Okay? So genetic testing will identify the CXCR4 mutation, and I think this is particularly important for WHIM syndrome because it may impact therapy. There is an open accruing clinical trial to study an inhibitor of CXCR4 to see if it can improve the outcome in these patients. So this is a quick overview of the genetic testing process. First step is you need to discuss with your doctor whether genetic testing is appropriate for you. If it is, you need to schedule an appointment to provide a sample or ask if you can provide this sample from home. In some cases, this is a blood sample, but like I say, it can sometimes be done at home. These results typically take a month or two to be received. Your doctor will receive the results and then share them with you. And then finally, once you have the results, you may want to schedule a time to talk to a genetic counselor to go over these test results. I'll go through some of these steps a little bit later. Next slide. So as I mentioned, the first step, if interested in genetic testing, is to talk to your doctor. Now, here are some of the questions you might want to ask. So first of all, have I had a genetic test before? If so, did it reveal a genetic cause for my neutropenia? If not, then repeat genetic testing might be worthwhile. This is important because the number of genes that are known to cause neutropenia or immunodeficiency is increasing every year. And the gene panels that we use to test have been increasing correspondingly. The current gene panels now contain over 400 genes. You may also want to ask whether or not the doctor's opinion that the genetic testing could it change my diagnosis? Could it affect treatment? And I think one of the final issues, and an important one, is whether genetic testing would be covered by health insurance. If not, this is a fairly expensive test. As I mentioned before, this is one of the major reasons why some people don't pursue genetic testing because of cost. Now, fortunately, if you qualify, X4 Pharmaceuticals is offering a free genetic testing program called the Path Forward, or rather Path Forward, and the links will be available, I think, somewhere in this seminar. This free genetic screen looks at 407 genes that are known to cause primary immunodeficiency and includes genes that cause neutropenia. Okay, next slide. Okay, with all medical tests, there are risks and benefits to consider before taking the test. So from my perspective, I've seen many patients who don't carry a genetic diagnosis, who have chronic neutropenias. They sometimes have this complicated diagnostic odyssey they go through where it involves numerous referrals to specialists, sometimes exhaustive number and expensive tests, some of which are not very helpful. All of these testing sometimes can delay the diagnosis and can delay proper treatment, and this can have consequences. Recurrent infections, if they're severe, can sometimes cause permanent organ damage. So for all of these reasons alone, I strongly advocate early genetic testing for all patients who present with severe chronic neutropenia. As we mentioned, the genetic test diagnosis may also suggest a new treatment option or clinical trial. And many of our patients are interested in genetic testing for informed family planning reasons. And finally, from a more altruistic point of view, genetic testing a large number of patients actually helps doctors and scientists understand the causes of neutropenia and then how genetic testing can be used. So in part, by participating in genetic testing, you may also help advance the field for others. Now, on the minus side, genetic testing is not informative in all cases. So in the Model study that I mentioned earlier, a change in diagnosis from genetic testing occurred in only 45% of cases. So this means a little more than half of the time, the genetic testing is not informative. There's another vexing problem that we see in genetic testing, and that is these variants of uncertain significance, or VUSs. So these are mutations or really genetic variants that we just don't understand if they do or don't contribute to neutropenia. Of course, any blood test has some very small risk of infection. I already mentioned that insurance may not cover if you go that route. And then I want to just touch briefly on data protection and privacy. Next slide. So, so the Genetic Information Non-Discrimination Act, or GINA, prevents the use of genetic testing or information to be used to impact health insurance. However, GINA does not cover some issues. For instance, it does not cover loss to long-term care insurance, life insurance, or disability insurance, and it also does not protect employment with a company that has 14 or fewer employees. Some states have additional protections, and I think that you can go to the Genome Statute and Legislation database that provides these list of protections by state. Next slide. So if your doctor agrees that genetic testing is indicated, the next step is to provide a DNA sample. You've probably seen this on TV shows, especially crime shows, that DNA is present in skin, hair, blood, and just about every tissue. So there are three main ways that the genetic testing are conducted. Is from the left, a cheek swab. Sometimes this can be done at home. You just have to rub the inside of your cheek to get some skin cells. There's the saliva spit test, which is shown in the middle. And finally, sometimes in the lab, in the office, it's easy just to get a blood test, and that's shown on the right. Sometimes they can also do a pinprick of your finger. Even a drop of blood is more than enough to get DNA for testing. Next slide. Now, just to kind of clarify, there are several types of genetic tests. You've probably seen advertisements for the direct-to-consumer tests like Ancestry.com and 23andMe. These are tests that are allowed by the FDA to directly advertise to the public. Anyone can request them. They don't require you to go through a doctor, and you don't really get the help of a healthcare professional or genetic counselor to interpret the results. So these are interesting tests, and they can be used. They would again require DNA, but they can provide clues about your ancestry. They have some degree of predicting health, again, to some degree. They can sometimes confirm paternity, and occasionally they can tell you if you're a carrier for certain diseases. But I would suggest that before you make any decision about your health based on these sorts of tests, you really should check with your doctor because there is some misinformation out there. Now, I would say that, go back a second, that these sorts of tests are really not designed nor sufficient for diagnostic genetic testing for persons with neutropenia. I would not use them. Okay, next slide. The other category are called diagnostic genetic screen tests. Now, these are tests that are available only through your doctor. They require a doctor to order them. The test results go back to your doctor or healthcare provider, who then help interpret the results. These tests can be used to establish a genetic diagnosis like neutropenia. They can also determine whether someone is a carrier for a certain mutation. And if both parents are tested, this can help establish the risk of a couple having a child with a particular genetic condition. Now, babies can sometimes be tested for genetic conditions before they are born, and all babies have newborn screening tests for some conditions. I should mention the traditional heel stick that you're seeing depicted on the right there is actually not a genetic test. Now, there's even people who use genetic testing for pre-symptomatic screening. This is sometimes considered in families who have a history of a genetic disorder or some kind of unexplained illness. And then, before patients have symptoms or pre-symptomatic testing can sometimes be done to identify genetic gene mutation that might inform on the genetic disorder, even before symptoms appear. Next slide. Now, some genetic tests only look for one or a few specific genes. And maybe the best example of neutropenia is the Elaine gene. So Elaine is the most common cause of severe congenital neutropenia. It's present in about 50% of patients. So you can order a test for Elaine, and that's a good test. But I will say that panel testing, so for instance, the 407 genes available in the Invitae primary immunodeficiency gene panel include Elaine. And they would cover some 27 or so other gene mutations that are known to cause neutropenia. So I think if you're starting out fresh, it really makes sense to me to go ahead and get the panel testing, which would cover Elaine and these other causes of neutropenia. So as I mentioned, the Invitae is a medical testing company that offers this panel of 407 genes that are known to be mutated in patients with primary immunodeficiency, including congenital neutropenia. And this is a test that is being offered through the Path Forward program at no cost to persons who qualify for the program. Okay, next slide.
Dr. Link, we do have a question from someone who is wondering, their daughter has been diagnosed with the Elaine mutation, and there's no knowledge of the disease on the paternal or maternal side.
Yes.
And they're wondering if it would be helpful to have specific family members tested to see which side it comes from.
Yeah, so I mean, let me try to handle this. So first of all, there's something called spontaneous mutations that happen. So an Elaine mutation only requires one of the two copies of Elaine to be mutated. It's an autosomal dominant mutation. So you would think then that mom or dad would have that mutation, but sometimes neither one of them have it, and that this is a mutation that arose in that child only. So we see that quite often with this sort of autosomal dominant mutation. So that's one thing. If the parents have had testing for Elaine and they are negative, then I don't think further genetic testing would make much sense there. Now, if you're asking about the bigger picture, if somebody, if the parents, we don't know what their genetic test, if they're mutated or not, then you could look at the parents, and that would really be most interesting or relevant for if the parents are planning to have additional children for family planning purposes. Okay. If that isn't clear, they can ask again. Okay, so after you take the test, like I said, it takes 1 or 2 months. The results are analyzed and a lab report is sent to your doctor. And we wanted to share a sample of this report to you. And I can't even read this myself, right? But it's really not so key. The real key thing here is this little box, the results table. And this kind of gives you an example, there you go, thank you, of the results. So, so in this, in this case, for instance, what they are saying is that this person has a mutation in one of their hemoglobin genes. If they have 2 copies, only one is mutated. So the interpretation, if you look, is that this person is a carrier, a silent carrier for alpha thalassemia. So, you know, and then they recommend potentially genetic counseling. So this is the kind of information you might get from a genetic testing. All the rest of it, if you look in this particular case, are basically negative data. So I think that Invitae and their genetic counselors do a really nice job, in my experience, in putting together these results in a really rigorous way. Okay, next slide. Now, as you kind of just saw, genetic tests can be confusing. I would say in some cases, maybe even overwhelming. So thus, you may want to discuss your results with a genetic counselor. A genetic counselor is someone who's an expert in the interpretation of genetic results. So what they would do is they would integrate the genetic test results with clinical features and family history when they interpret the results. They would then, you know, communicate this kind of integrated results to you and try to help you understand what this means in your particular case. So it's a very useful service. And I think one of the really nice features of the Path Forward program is that the free genetic testing program also comes with an offer of free genetic counseling. So something that if you do go through this program, I would suggest you take advantage of that. Next slide. So kind of here's the summary of the genetic testing process. So first step is talk to your doctor to see if it's appropriate for you. If so, schedule an appointment to provide a sample or provide a sample from home. When the test results come back in 1 or 2 months, your doctor will get the results and let you know, meet with the doctor and go over the results. And finally, my suggestion would be to go ahead and schedule a time to talk to a genetic counselor about these results. Next slide. So if you'd like more information about genetics, genetic testing, genetic counseling, here are some great resources. This ideuropid.com was just launched. I actually just looked at it myself today for the first time, and it has some of the some really good information on genetic testing, and including some of the slides that are being presented here today. The Invitae Path Forward link is shown on the right there. This is the program that offers free genetic testing and counseling if you qualify. And finally, the Medline Plus is a NIH resource, which is really a go-to place for basic information about diseases and genetics and how that works. Next slide. So kind of looking ahead, I think that, you know, genetic testing for persons with neutropenia and primary immunodeficiency is increasingly becoming important. As we learn more about the genetic causes and how these genetic mutations inform the clinical management of patients. So in my practice, I recommend genetic testing for virtually everybody who has unexplained chronic neutropenia. And this is one of the first tests that I recommend, especially, and I've utilized the Invitae, the Path Forward program myself, because I think that genetic testing can really help establish a clear diagnosis, save a lot of unnecessary testing, and then potentially inform outcomes. So my recommendation to the community out there is to consider talking with your doctor to see if it's appropriate for you or your family member. Last slide. So I think that now's the time, if you have any questions for either me or Kate, please submit them now, and we'll see if we can answer them. Thank you.
Yeah, Dr. Link, we have another question from Craig who's wondering if someone's diagnosed with a neutropenia and then is cured through a stem cell transplant or has CRISPR genetic editing,
Yes.
does that mean that they don't carry the same risk to their offspring?
Yeah, good question. The answer is that no. Yes, they are still able to transmit to their offspring. The stem cell transplant and the CRISPR gene editing will not affect at all your transmission to your offspring. So the risk is the same.
And you can submit questions if you would like via the chat function or Q&A. So we'll just pause for another minute to give people a chance.
Okay, we have another question. Can genetic testing help diagnose cyclic neutropenia?
Yes. So about 90% of cases of cyclic neutropenia are due to mutations of the lane, and about 10% are not. But I would still recommend using the gene panel to help try to pick up that 10% that's not a lane. Yep. Yeah, I see the question. Are gene editing trials underway, and when might they be approved of use? So, yeah, I think early planning for gene editing trials are going, as you, Craig, may know, that at the last American Society of Hematology meeting, one of the premier talks, called plenary talks, was preclinical data suggesting that gene editing for lane in particular might not be too far away from the clinic. But I would say that this is years away from being approved. I think that if you're really interested, you would have to see, and I'm not sure if the clinical trials are open yet, honestly, but if you really were interested in, you would consider finding a clinical trial, because it's not likely to be FDA approved for many years, in my estimation.
And if you're interested in learning more about clinical trials, we did another webinar on Clinical Trials 101, and you can find that on the National Neutropenia Network website and YouTube.
Yeah, I was just looking back at your original question, Craig, about a daughter, 2 years old, who diagnosed with SCN due to an lane mutation. If both parents are asymptomatic, in which they don't have neutropenia, then it's very unlikely they carry the lane mutation, and that mutation was most likely a spontaneous mutation. It's still, if the parents are thinking about having more children, I still would recommend genetic testing, because there is a possibility that they are carriers, although it's unlikely.
Okay, we have another question here. Should all the family members get tested if a mutation is identified, even if there are no symptoms?
I would say no. In general, I would say no. I think that I think this is, I should probably qualify it. What I would suggest is you talk to a genetic counselor. So for some conditions, a person might be asymptomatic, but would be at risk for symptoms later. And so in that situation, if I was a parent, I'd want to know whether or not the person had the mutation. Some conditions, though, like severe congenital neutropenia, present right at birth, as you know, And so it's not likely that's going to manifest lately. So if somebody is asymptomatic in 3 or 4 years old, then there would be little value in testing that person in my mind. So I would say this is where genetic testing would make really good sense. I mean, I'm sorry, genetic counseling to guide that answer.
Yeah, and I think you said earlier that if you've already been diagnosed with the Elaine, that you would recommend getting the full panel as well. Is that right?
No, I would not recommend that. So if somebody has an Elaine mutation, that is thought to be a pathogenic Elaine mutation, that explains their neutropenia. And I think doing additional genetic testing in that case would not make sense. But I'm saying if somebody comes to me with congenital neutropenia, I don't order the Elaine test alone anymore. It's just more efficient to go ahead and order the panel, especially since it can be done free now. And then you'll get Elaine, and if it's there, you got it. But if it's not there, you have a chance to pick up one of the other 28 or so gene mutations that are known to cause neutropenia. So I see another question. Is there any correlation or difference between IVF birth or natural conception? So that's a good question. And as far as I know, especially with neutropenia, there is no association. Simple answer. I see another person who asked the question about, do you believe Neupogen is the best treatment for sickle neutropenia? And you're right, it's off target, but that's okay. The answer is it is the best treatment. So in patients with sickle neutropenia, what's important is that you titrate the dose of G-CSF at the lowest possible dose that can get your neutrophil counts to a stable level. And so we've shown that that can be very safe. As part of the severe chronic neutropenia international registry that I'm part of, I think we've shown that that can be very safe. So, but it's usually a dosing that can sometimes be once every other day, sometimes once every 3 days, and often at a lower dose. But yes, sickle neutropenia is still treated with G-CSF.
Okay, we're going to do a last call for any questions. So if you have any further, please submit them now.
So I see another question. Is it common for the neutrophil counts to vary once someone has been on G-CSF for a year? Yes, it is. There is some variability in counts, and that, I don't think we understand why it's variable, but this is why typically we recommend that counts be checked on a periodic basis. Once you get to a dose of G-CSF, counts can usually be stable within a range, but there are things like infection that can change it. And over time, people can become resistant to G-CSF. So that is something that needs to be followed also.
Okay, well, thanks everybody for all those really great questions and the discussion. So we'll turn it over to Kate to wrap up.
You're on mute, Kate.
Sorry, everyone. Thank you again, Dr. Lank, for being here today and facilitating the webinar. We appreciate it. Also, again, thank you to X4 for your partnership with the National Neutropenia Network as well. And thank you to everyone who joined the webinar today. We hope you found it useful. We hope you enjoyed the presentation and your questions about the genetic testing. We hope they were answered. We will be sharing the webinar through our website as well as our YouTube channel. So if you want to check it out again, please feel free to check it out there and visit our website for any more support. Thank you, everyone, and have a great weekend.
Thank you. Goodbye.